Okay, so I'm going to speak in next 10 minutes or so about the novel antihypertensive drugs. And by way of introduction, let me say that what is the need for new antihypertensive drugs? That is the first question. From 1980s onwards, in the past 4 decades, changes in antihypertensive drug treatment have largely focused on attempts to develop better calcium channel blockers, better ACE inhibitors, better ARBs, or return to forgotten thiazide diuretics like chlorthalidone, but nothing very substantial by way of new classes of drugs, new targets for treatment, and this is reflected in our inability to control blood pressure effectively in all antihypertensives, substantial number of patients with resistant hypertension, and therefore the clinicians often rely on drug combination, 2 drugs, 3 drugs, 4 drugs, even 5 drugs sometimes. And then it goes without saying that the capability of the current antihypertensive drugs to prevent the organ damage is rather limited. You can measure that in terms of relative reduction, 10%, 20%, 30%. But if you look at the absolute risk reduction, it is more or less than 10%, say for example. And this is not surprising because hypertension is basically derived from a very complex system of RAS, which is more complex than we usually think in terms of how to manipulate it in terms of ACE inhibition and ARBs. And we also know the limitations of ACE inhibitor and ARBs, like ACE escape phenomenon. ACE inhibitors result in increase in the angiotensin 1 level and activation of the ACE-dependent pathways to convert angiotensin 1 to angiotensin 2, so thereby reducing the efficacy with continued use. Similarly, ARBs, they increase the plasma renin activity as a feedback phenomenon, which increases the angiotensin 2 levels. And competition between angiotensin 2 and ARB for AT1 receptor results in a decrease in the efficacy of AT1 receptor. So if you really look at what is really the development, it's not, to my mind, it is not finding or marketing new calcium channel blockers like azilidipine or ranitidine or cilidipine, or going back to the older agents like chlorthalidone or some thiazide diuretic. Actually, we should be targeting RAS in a more effective manner, because RAS overactivation plays a central role in the pathogenesis of hypertension. And therefore, I agree with that current drug development is focusing on the areas of novel targets of RAS that serve the dual purpose of not only better blood pressure control, but also improve the function of organs which are burdened by hypertension. That means end organ damage, which may or may not be directly related to a decrease in blood pressure by RAS inhibition. And as I said earlier, RAS is a more complicated system than perceived by most of the clinicians. Just to give you an example, what about the role of AT2 receptor? It is thought to be beneficial. The expression of the AT2 receptor is maintained at low level under healthy conditions, but it is drastically upregulated as a compensatory and protective phenomenon for diseases, for cardiac disease, renal disease, and it does promote the tissue repair, cell differentiation, and promotes diuresis and natriuresis. So that may be one of the targets. But unfortunately, so far, there are 4 AT2 receptor agonists which are being used in clinical trials, not in clinical, but preclinical trials. So I will not go further into that, but focus more on what is known as ACE2 angiotensin 1 to 7 and MARS R protective axis. Now, what is that? See, basically, you have an ACE inhibitor, you have ACE2 inhibitor, ACE2 enzyme also. Now, ACE2 enzyme has a high affinity towards the peptide angiotensin 2 and converts that into angiotensin 1 to 7. And this also converts angiotensin 1 into angiotensin 1 to 9. And that ultimately gets converted to angiotensin 1 to 7. Now, this axis of ACE2 angiotensin 1 to 7 and MARS R axis basically has a protective action theoretically. Now, can we really manipulate that into something that is going to be beneficial for patients with hypertension with or without and organ damage. Well, let me say that with this introduction as to what are the potential targets that are being used, and then I will come to the trials, the clinical trials in progress, and the future, glean into the future as to what can be available to us in very near future. So you have, several novel peptide and non-peptide based agents that are currently at different stages of development. And I will go towards these one by one. I already talked about 82 receptor agonist. Let me say about ACE2 Ang1 mass R axis activators. Now there is an ongoing clinical trial which is testing a recombinant form of ACE2, which is supposed to be beneficial for the reasons I mentioned for the treatment of cardiovascular disease. And it has shown promising results in reducing the progression of diabetic nephropathy, reducing blood pressure, and reducing the progress of cardiac fibrosis. But this is in initial stages, so it is possible that we may have something like that in future. But the peptide Ang1 to 7 directly, a recombinant form of that is also showing promises in treatment of cardiovascular diseases, including the hypertension patients. It has also got an antiarrhythmic action, and it also inhibits the cardiac remodeling. And there is a non-peptide agonist of mass R, which mimics the action of the endogenous Ang1 to 7 by vasodilation and natriuresis in many tissues. But still, we don't have any phase 3 clinical trial with this. Now, what about the natriuretic peptides and their synthetic analogs? Now, natriuretic peptides, they cause vasodilation, they have natriuretic effect and diuretic effect, and they have a potential therapeutic alternative in hypertension treatment. And they also are protective, and they protect against glomerular injury, which is also a very important target for endpoint in patients with hypertension. Now, but they are destroyed very rapidly in the circulation. So we have designer natriuretic peptides, and one of that is MANP, which has been demonstrated to be safe and highly efficacious in reducing the blood pressure with a single subcutaneous administration. And it also got a renal protective action and also reduce the aldosterone level. Neprilysin inhibitor alone is also beneficial theoretically, but in clinical trials, it has not been shown to be beneficial in reducing blood pressure and organ damage. And the combination of neprilysin inhibitor along with valsartan, that is available. There is no trial going on with this, but I feel that there is a potential for this because this combination also has got a protective action. Now, coming on to the soluble guanylyl cyclase A stimulation, which is instrumental in releasing the cyclic AMP in the cells, and this is activated by the nitrous oxide. This is something that has got a great potential, and the soluble SGC stimulation have shown promising anti-fibrotic, anti-hypertrophic, anti-inflammatory, and anti-hypertensive effects. Then there are dual-acting bispecific peptides, and this peptide engineering with a multivalent strategy. That means not only they activate the guanylyl cyclase A, but also they also activate another form of guanylyl cyclase, which is called GCB. And this combination basically is not the only one. We have a combination peptide which mimics the action of BNP as well as ANG1 to 7. So, a great potential for reducing blood pressure and target organ damage. Now, coming on to non-steroidal mineralocorticoid receptor antagonist. Now, this is something that one needs to focus on because it is in advanced stages of phase 3 trials, and effectively they don't have any effects on urinary electrolyte excretion, so less risk of hyperkalemia and better blood pressure reduction. So randomized clinical trials, and one of the newer non-steroidal mineralocorticoid receptor antagonist is phenereston, basically, which showed a significant improvement in subjects with worsening chronic and renal disease conditions. Comparison was made with eplerenone. So, we have other things like aminopeptidase inhibitors, insulin-resistant aminopeptide inhibition also. But let me just close this by saying, just 1 minute more, that what is actually happening, how many clinical trials are actually happening with these novel strategies, and what are their phases? Well, there are at least 27 clinical trials which are ongoing, 10 of which are phase 1 trials, 12 are phase 2 trials, and 5 are phase 3 trials. Not all clinical trials are, of course, being conducted in hypertensive patients. Several of them are recruiting patients with various cardiovascular and renal disorders. And I feel that at least 2 or 3 of the molecules that I have mentioned, they are going to find their way into the market after proper phase 3 trials. And these may prove to be better or at least competitive with the current antihypertensive agents, particularly of the RAS inhibitor reason. But so there has been a tremendous development that is going on in BP control and prevention of end organ damage, and there is a scope, and clearly a scope, for further improvement, as suggested by need for multiple drug therapy and the residual risk despite the best available therapy. And the main target of these newer hypertension management strategies is multiple RAS targets beyond the ACE, ANG1, and AT1 receptor axis. So I will close here and maybe open to question. Thank you very much.